Osteomyelitis by Phuong, Nguyen, and Seth, Swanson. Osteomyelitis is an inflammation of the bone and/or bone marrow. The most common causes are by microbial infection that reaches the bone through abscessed teeth, periodontal lesions, post-surgical infection, or traumatic injuries. Osteomyelitis can be classified as either acute or chronic based on the differences in the host response and the causative agent. Signs and symptoms for acute osteomyelitis include pain, paresthesia of the lower lip, lymphadenopathy, purulent exudate, and a fetid oral odor. Swelling and fever can also occur. Teeth in the affected region may be mobile.
Chronic osteomyelitis generally has a less severe symptoms and longer history than the acute form. Signs and symptoms include mild to moderate pain, lymphadenopathy, sinus tract formation, recurrent swelling, variable fever, and loose teeth. On the right is an example of an intraoral draining sinus associated with chronic osteomyelitis. Osteomyelitis is a rare disease with an incidence of 25 in 100,000. There's a high prevalence in males, particularly in the 50s to 60s. People who are at an increased risk include those who have undergone radiotherapy and the immunocompromised.
For the radiographic findings of location, the most common location for both acute and chronic osteomyelitis to occur is the posterior body of the mandible. Maxillary involvement is rare for both cases. The extent of the lesion can be generalized or localized as well as bilateral or unilateral. The pantograph shows a case of osteomyelitis in the left posterior mandible. The edge. Acute osteomyelitis has an ill-defined border with a gradual transition to normal trabecula. The chronic form is better defined than the acute form, having a well-localized to ill-defined periphery. There is no defined shape for osteomyelitis.
Acute osteomyelitis has a mixed radiolucent radiopaque presentation. The trabeculation pattern has a loss of sharpness. Sequestra may be present, which are necrotic pieces of bone. They appear as islands of non-vital radiopaque bone surrounded by a region of radiolucent bone. The chronic form is also mixed, with mostly a radiopaque or sclerotic bone pattern. Sequestra are more common in chronic. Computed tomography is the best imaging technique to visualize internal structures in sequestra. On the right is a CT scan of a sequestrum in the mandible.
For other structures, acute osteomyelitis may lead to bone formation or bone resorption. The cortical bone is often resorbed. The periosteum may be lifted by an inflammatory exudate which stimulates bone formation adjacent to the bone surface, leading to an onion skin appearance, which is also called proliferative periostitis. On the right, the white arrows indicate a proliferative periostitis in the mandible.
Formation of new periosteal bone is often associated with chronic osteomyelitis. The radiographic proliferative periostitis may also be seen. Teeth in the affected region may undergo external resorption along the whole surface. Draining fistula may develop, which appears as a break in the cortical bone. The lesions for both forms of osteomyelitis can be single or multiple. The size of the osteomyelitic lesions can also be variable.
For treatment, the primary objective of the treatment of acute osteomyelitis is to remove the source of inflammation. Antibiotics are recommended along with the establishment of a drainage pathway. Tooth extraction, incision and drainage, or root canal therapy may be indicated as an appropriate treatment.
Chronic osteomyelitis is often more difficult to treat than the acute form. Surgical interventions such as sequestrectomy, decortication, and resection may be indicated. The type of surgery depends on the extent of the lesion, with elimination of all infected and necrotic tissues as the goal. Use of hyperbaric oxygen is also advocated, especially in the irradiated mandible. The picture below is a case of chronic osteomyelitis in an elderly man. Sequestrectomy was done to retrieve the sequestrum that is shown on the right.
The differential diagnosis for acute osteomyelitis includes fibrous dysplasia and malignant neoplasia. Malignant neoplasia includes osteosarcoma and squamous cell carcinoma. Fibrous dysplasia can have a radiographic presentation of mixed radiolucent radiopaque similar to osteomyelitis. Malignant neoplasia can have an ill-defined border and a mixed internal structure. The differential diagnosis for chronic osteomyelitis includes Paget's disease of bone, fibrous dysplasia, and osteosarcoma. Osteosarcoma and fibrous dysplasia are included for the same reasons as acute osteomyelitis. Paget's disease of bone can result in expansion of the mandible and can have a mixed radiolucent radiopaque cotton wool appearance.